Hi, my name's Mark Lovell. I'm a consultant child and adolescent learning disability psychiatrist working for Tees, Escombe Wear Valley's NHS Foundation Trust. I'm also the lead for CPD and training for the Association for Child and Adolescent Mental Health. This talk is based upon a framework that I designed called the Identification of Intellectual Disabilities Framework, A2H. This is for children, young people and adults. So, what is an intellectual disability? An intellectual disability is an IQ of 70 or below within DSM-5, which is the American Psychiatric Association criteria. However, within the World Health Organization criteria, ICD-10, an intellectual disability is actually 69 or below. So there is a difference in an IQ point depending on which system you use. You also have to have significant difficulties with your adaptive behaviours. Adaptive behaviours are your activities of daily living. So your daily living skills to do with feeding, getting yourself dressed, managing time, coordinating yourself with friends and family, and a whole variety of daily living tasks. There are 4 major levels. These are mild, moderate, severe, and profound. And these all relate to lowering numbers of IQ points. An intellectual disability is also known as a learning disability within the UK. This, however, overlaps with the term learning difficulty, which is an educational term. Generally speaking, a moderate to severe or below learning difficulty in educational terms will relate to a learning disability. There are overlaps with the term global developmental delay, which is a paediatric term, and caution should be sort of held, particularly when reading research or books or information from the US, where historically learning disability also included specific learning difficulties within UK terminology, such as dyslexia. That can make it very difficult to sometimes work out what a piece of literature or a book is actually about. So, the IDID A2H Framework. I created this as a response to a lack of information out there really about exactly what an intellectual disability is, but also how to use different bits of information that you may gather along the way to make a decision about the likelihood of a learning disability or intellectual disability. This framework is not diagnostic in its own right. It is a framework for gathering information, for sharing information, and to conceptualize and think about and formulate and generate a needs-based plan for an individual. It is used primarily to assist in decision making. There are long and short versions of this framework which are available through www.acamh.org within the Intellectual Disability Topic Guide. There is extra information and resources for gathering information as a professional, and also an information leaflet for parents and carers with regards to what information they might want to bring to an assessment of a young person or adult's intellectual disability. So it's an A2H framework, so it goes alphabetically. These are not necessarily logically in order, but they had to fit the alphabet. So A stands for academic. This is all about academia and education. So what are that individuals, or were that individuals' expected attainment levels for their age? You need to bear in mind that there is a range on attainment levels from the most able child in a class to the least able child at a certain age. You would also need to think about what are their current or past academic attainment levels. So this is results from exams, their reports and levels from schooling, college, and other educational establishments. And do we know if they have a specific learning difficulty, such as dyslexia or dyscalculia, which would give us some more clues about where their difficulties may lie. Information from an educational establishment from the past or current is really important when assessing for an intellectual disability, particularly when we're looking at how far behind somebody may be academically, and does that fit with their IQ and their adaptive behaviours, Are we seeing any spurious results within that system? And it's really important to know how well a child engaged with education and did they actually attend when they were a child. It's important to know what education establishments they went to. Did they go to a specialist provision? Were they receiving extra help? Were there any sort of reasonable adjustments made to their education? And did they have a statement of educational need in the past or an education health care plan using the English terminology with regards to extra plans that get your educational needs met? And what was it for? Was it for behaviour? Was it for learning? Was it for a disability of a different kind, perhaps that they needed provisions for visual impairment, hearing impairment, or that they had additional physical health needs? B is behaviours of everyday living. These are your adaptive behaviours. There are a range of specific standardised tests available, and this list isn't exclusive, but these may include the ABAS, the ABS, or the Vineland. These standardise your ability with regards to your daily living skills, and generally you would get information from a parent or carer and also an educational report. And from those scorings, if you're in the lowest 2 percentiles, so in the bottom 1 out of 50 people or the bottom 2 out of 100, on average, you would be presenting within intellectual disability range. It's really important to get these results or information about this because this adds to a diagnosis. C is for cognitive assessments. These are standardised assessments or tests, usually carried out by psychologists who are trained in the delivery and the interpretation of these. There's a whole variety of these based upon age, particularly, or by country, and also by length. So some of the examples might be the Wechsler nonverbal, the WIPSI, which is for preschool age children, the WISC for children, the WACE for adults. But also in the UK, or in England particularly, we have the BAS, which is used by educational psychologists, which is the British Ability Scales. And there may be short forms and brief assessments like the KBIT2. There are others available on the market, and this list is not exclusive. There may be some other results from neuropsychology, such as the RAML or other tests, which might give you information specifically about, say, memory or processing, and a whole variety of other skills and function that may be to do with neurological functioning. It's important to know if there are specific deficits there. It's really important to know, has a diagnosis already been made? If that is the case, then you may conclude the same from this assessment or from this framework, or you might decide that something has changed. Somebody may have deteriorated in skills, or they might actually have improved in skills, or the original results weren't interpretable, or the ones that you're gaining now might not be interpretable. You're using all the information available to you. D is for development. There are a whole variety of aspects of our lives that we develop within as children and into adulthood. It would be useful to know if there are any standardised tests that have already been done, such as the Schedule of Growing Skills, the Denver 2, which may be carried out by paediatrics or within child development centres, the KELF and KELF 2, which may be carried out by speech and language therapy, British Picture Vocabulary Scales, or Bailey's, which is also another assessment of development. There are a whole variety of these assessments on the market, and they can give you a clue as to how delayed and in what domains somebody might have delays. Information may also be gathered about development from paediatrics, physiotherapy, occupational therapy, speech and language therapy, health visiting, GP, portage workers, etc. There's a whole variety of professionals that may be involved with developmental assessments and treatments. It's important to know if there are any existing diagnoses already in place, or if there were global developmental delays. Unfortunately, global developmental delays do not have a level of delay attached to them, and it is a term that should really be used before the age of 5 and then converted to something else after 5. We develop in a whole variety of areas, so speech, language and communication, gross motor, fine motor, our social skills, our play skills, our behaviours develop over time, and also our senses develop. So it's really important to think globally about somebody's development, about impairments and needs, and also about strengths. E is for environment. This is information from the home setting, such as parenting style, stability of placement, also from the school setting. Was the child or young person in a specialist provision? Did they go to school? Did they have a peer group? What was their peer group like? For instance, if you went to a mainstream school and you're the only child with a disability, your peer group may not resemble that child, or that may have caused difficulties with peer relationships. Was the child looked after or adopted? That may give some clues about early life experiences, but also about stability of placement around a child. You may use information from social care, such as safeguarding or VEMT proceedings. A whole variety of information may be available to you, particularly around past experiences, and in particular about adverse childhood events, traumatic experiences such as abuse, stability of placements, etc., etc. F is factors, so other factors that may be at play. So consideration of somebody's mental health. If you have an intellectual disability, you have an increased chance of mental health problems. But if you're mentally unwell at the time of your assessment, it may impact upon your current functioning, and it may give you a diagnosis that you may develop back out of if your mental health is treated. So you need to bear that in mind. Behavioural conditions such as autism spectrum disorder, ADHD, and behavioural difficulties such as challenging behaviours or behaviours that challenge others are also very important to consider, because they may impact upon schooling, engagement with tests, but also may interfere with the test results, such as if you have difficulty concentrating, or if you have difficulty with understanding questions about social situations. Those will interfere with your results and your functioning in everyday life. Physical health is also very important, particularly if the physical health involves your neurology and your central nervous system and your brain. So conditions such as epilepsy or a head injury, fetal alcohol spectrum disorder, hearing impairments, visual impairments will all impact upon your ability to do tests and function within your everyday life. They're also very important to bear in mind. If somebody can't see, for instance, they're not going to be able to do parts of tests that are visual. Or if they can't hear you, they're not going to either engage with education or learn and understand over time, but also unless there are provisions put in place to compensate for the hearing difficulty. But it's very hard to do a cognitive test if you can't hear the instructions. So those aspects are very important to consider. And for instance, if you're having a seizure, or you've just had a seizure before your cognitive assessment, you need to wait and do it later when you're not post-ICT or after the seizure. Genetic conditions are very important. There are many genetic conditions that are directly linked with intellectual disabilities and other neurodevelopmental conditions. And these need to be considered either to give you a clue that it is very likely that there is an intellectual disability, or that it may raise your sort of interest or clinical sort of thinking about that you need to assess for one. Attachment is what happens between a child and their primary caregiver. If you have an attachment disorder or difficulties, that may seriously impact upon your learning, your engagement, particularly socially and with communication and language. And this may continue to interfere with peer relationships, your daily living skills, and your engagement with education. So it's important to know about attachments and past or present abuse. This, we know that abuse occurs more commonly in those with intellectual disabilities than the general population. We also know that it may have happened in the past or currently be occurring, and we have to bear in mind, is now the right time to do an assessment? If someone's very traumatized at this moment in time, it may not be a good time to do an assessment, or that you may need to engage that young person for a period of time to be able to get the best out of them during any testing, so that they can trust you as an examiner, as a psychologist, for instance, doing a test, to get to know that child before doing the test. It may also be traumatizing being tested, because if the young person understands that there may be some outcomes of this and that they may be presenting themselves as potentially failing something, some of the styles of behaviour and engagement with people may be impacted upon by sort of abuse and attachment disorders. G is about general impression. So with the collected information, you need to consider, is it likely the child or adult has normal intelligence, learning difficulties, or an intellectual disability, or that you still don't know? Can anything else explain that child or adult's presentation at this moment in time? Do they have any comorbidities or co-occurring conditions that either raise your chances of having an intellectual disability or that need to be considered in greater detail to think through what's going on? Particularly, for instance, say if you identified at this moment in time that somebody was scoring on their assessments as having an intellectual disability, but they also have ADHD that was untreated. ADHD impacts upon your hyperactivity levels, or your activity levels. It impacts upon impulsivity, as well as attentional levels. If you can't sit still, you're impulsive and you struggle to remember things or stay on task, it's very hard to do an assessment. So sometimes you may need to go away, treat the ADHD, and then return, when stable, to looking at intellectual disability again, because often IQ points may go up. It's important to consider what is this individual's strengths and difficulties. What are their strengths and difficulties? Because we are heading towards making a needs-based plan and how to meet those needs. Knowing that someone has an intellectual disability is all very well, but we need to do something about it, such as reasonably adjusting to their needs, but also ensuring that their wider needs are also met. So H is the final section, which is how to meet their needs. And this is about generating a needs-based plan upon all the information that you've gathered over the A to G components of the framework. And this will consider mental health, behaviours, other diagnoses, physical health, education, social care, and health in general. So it's really, really important to think through meeting somebody's needs as the primary outcome of this framework, rather than just the diagnosis. Irrespective of whether a diagnosis is made, this person has been presented for an assessment. It is likely that they do have some additional needs that need to be met. So within the ACAMH website, there is a written version of most of what I've said. There's a short version and a long version, and some information for parents and carers. These versions can all be freely used and distributed and printed out, and should anyone want to use them clinically, there is a clinical framework, and this resource itself is either here to be shown to others freely, or the slides can be used and adapted if necessary to local service, and you can use a set of slides. It's all freely available but are copyrighted, so cannot be used commercially. However, if you wish to use these in any great detail, I would like to know about your experiences, and you can contact me through mark.lovell@nhs.net. So thank you for listening to this presentation, and good luck with using the framework.